today's discussion is rhinoplasty, and in this particular presentation, I'll be discussing the basics only, especially for residents, how they should approach a patient for rhinoplasty who request a rhinoplasty, and how to analyze the deformity and what are the basic steps of an open rhinoplasty. So you see, rhinoplasty is a very common procedure which all of us would have done and the residents would require to do. So it is considered both art as well as science. But the problem is that since nose is at such a prominent location, there is very limited margin of error. And in case you go wrong at a very minor place also, it will be noticed by each and everybody. So there is a very limited margin of error. And also we have to look at the existing anatomy of the nose. So in our Indian subcontinent also, we have different types of noses, different ethnicities, like from northeast region to down south to north. There are different types of noses and each one has its own peculiar characteristics. So we cannot fix a particular surgery to the particular nose. So we have to look at all these things. So we have to look at the existing anatomy of the nose. We have to look at what patient desires and what you can deliver. So coming to the basics first. So nose is like the skin covering the nose is very thick over the nasion region. Similarly, it is very thick over the lower 1/3 of the nose, but it is very thin over the central 1/3. The importance of this is any margin of any abnormality which will be left between bone and the cartilage level will be easily noticed by everybody else. So we cannot have any trouble here. And the second thing important is that it is very thick over the lower third of the nose. So in case this is sort of forgiving for us in India, but in case of Caucasian races, it is not that thick. So then any cartilage graft, in case it is not properly trimmed, it will show. So this is the importance. And as far as our Indian noses are concerned, so in case you want to bring any projection to the lower 1/3 of the nose, or you want to have any cartilage grafts, then a large amount of grafts have to put to bring any fruitful result because of the overlying thick skin on the lower 1/3 of the nose. We all know the cartilaginous framework consists of a pair of alar cartilages, a pair of upper lateral cartilages, and along with some small cartilages in the lateral aspect, septal cartilage in the midline, and all these cartilages are joined together by various fibrous connections. Like these are suspensory ligaments between the lower lateral cartilages and fibrous connections between the upper and lower lateral cartilages. So though it is not the topic of discussion today, so now we are moving towards preservation rhinoplasty, in which we want to preserve all these structures. But today we'll be discussing open rhinoplasty, in which we more often than not divide these structures. So importance is we have to reconstruct them again once we are done with the cartilage refashioning. So as far as the bony framework is concerned, we have a pair of nasal bones and two ascending processes of maxilla which form the lateral nasal wall. And in the midline, we have perpendicular plate of ethmoid, vomer, and nasal crest of maxilla and the palatine bone. We should also be aware about external as well as internal nasal wall. Usually we focus only on the external nasal wall. So it is primarily formed by ala and the part of the lower lateral cartilage. So it accounts for around 10 to 15% of nasal airway resistance. What is more important is the internal nasal valve. That is the overlapping part between the upper lateral and lower lateral cartilages, along with the inferior turbinate on the lateral aspect and septum on the medial aspect. So this accounts for more than 50% of airway resistance. So we must perform a Cottle's test and see whether the patient has some internal nasal valve obstruction, because performing a Cottle test the patient will have some improvement in airway resistance. So that means that we have to do something about the internal nasal valve while doing even a aesthetic rhinoplasty. So it is both aesthetic as well as a functional procedure. So what is our goal? Our goal is to have a nose which is not very conspicuous, Most of the patients are bothered because either the nose is not matching that ethnicity or they have some deformity. But we have to do this while preserving the functional aspect of the nose. We have to give very much importance to this aspect. In case the patient has some airway obstruction after the surgery, he or she is not going to appreciate the results which you have tried to achieve. And another point, rule of thumb is address the deformities that are bothering to the patient. Don't try to create a signature nose. We'll discuss about it. So the first and foremost thing when a patient comes for a initial consultation is to click all these photographs. All of us know about these views. First and foremost is the frontal view. This is one view which will give you so much of information. You can have a look at the nasal length, and what is important is the thirds concept. In case the patient's nose falls into this, the patient nose should be in the middle 1/3. It should not be more than 1/3. So that will give some idea that what you need to do. Then you can also have a look at the the nasal width, both at the mid-word level as well as the alar level. And also with this photograph, you can have a view of the aesthetic lines, dorsal aesthetic lines. You can know whether the patient is having a C-shaped deformity, S-shaped, or any other type of deformity. It also gives us an idea about the nasal tip. These are the tip defining points, whether the nose is broad or bulbous, that can be identified and conveyed to the patient. And also we can see in this single photograph what is the status of infratip lobule, whether the patient is having some overhanging of the lower part of the nose. Then is the lateral view. This also is a very important view. It gives us the profile view of the nose. So we can see whether there is a dorsal hump or a saddle deformity, or there is any cyprotip deformity. Like in this particular photograph, there are none. We can also see the various angles, nasofrontal angle, similarly the nasolabial angle. This is the tip projection, that is how much is the tip projecting, and this is the tip rotation. So oblique view will provide you an overall idea of what you have already learned in frontal and lateral views, and will give you a better appreciation of the deformity, and especially because we know the lateral nasal walls are a bit concave. So these views are also very important to look at any deformity, especially in patients with operated noses or secondary rhinoplasty. Another important view is the worm's eye view. So this will give you an idea of what is the status of the columella, whether the nostrils are symmetrical, whether there is any columellar deviation, and when the patient is breathing, what is happening to the external nasal valves. So in case they are collapsing, you might need to do something for the tip. And also we can come to know about any septal deviation. In case there is a tip deviation, you can see the septum jutting out in one of the nostrils. So in addition, you should also have some functional views like inspiratory views and smiling views. Sometimes the depressor septi is very prominent and patient is not happy about it. So you have to identify that and keep a record of that. So what is the next step? So when you have clicked all these photographs, you sit with the patient, review the photographs with the patient, and make him or her appreciate the different views and ask the patient or the person what are the bothersome deformities he or she is bothering about. So that also gives you an insight into the psyche of the patient. If the patient is focusing too much on the minor problems or he has unrealistic expectations, that is a red flag. So rhinoplasty patients, especially a male rhinoplasty patient, you have to really see the patient's expectation and whether he is suitable for the procedure or not. You have to look at various factors. There are numerous which are described, but grossly unhealthy motivating factors are: is the patient has recent family conflict or recent divorce after which he has come for rhinoplasty consultation, or whether there has been a major life change in his current scenario which has pushed him into rhinoplasty, or does he have some inadequacy which he focuses on rhinoplasty, like he's not doing well in his job. He thinks that he or she thinks that because of his prominent nose or abnormal nose, what he thinks is the cause of his not doing well. You look at the overall immaturity of maturity as well as immaturity and take a call accordingly. All these are very important because most of the cases of poor post-operative patient satisfaction are secondary to emotional dissatisfaction of the patient, not as a technical failure. Technical failures can, in case you're talking to the patient, can always be addressed in secondary rhinoplasty. But in case the patient is not a good candidate, so he or she will always be dissatisfied and will pin all the blame of his life, his career on single surgery and the surgeon. So you have to be very careful. So finally, once you have identified with the patient, he is a good candidate, you should do some nasal analysis. That after all these photographs, you know about the nasal width, nasal length, what you need to do in the particular surgery. Whether you want to tip to be projected upwards or projection to be increased or tip to be rotated downwards. All these things have to be clearly rehearsed in your mind and marked on a paper. So basically our aim is to restore nasal-facial balance and harmony. Also, we cannot stress it too much that record keeping is very important. Rhinoplasty patients, close to 20% patients will require a revision rhinoplasty despite your best efforts in the first surgery. So you have to do a meticulous record keeping. So the Gunter's chart are one way of doing this record keeping. And for residents, I would like to tell that whenever you remove anything, it is marked in red. They are color coded. Whenever you put a graft, it is marked in green. Grafts are marked in green, and the sutures are marked in black. And all the osteotomies, bone are marked in red. So these come in handy whenever the patient comes for follow-up. You can give a copy of these to the patient because sometimes patients are from outstation and they may change their jobs and may not be available. The surgeon, other surgeon will know what has been done. So coming now to the surgical part of it. So earlier there was always a debate between open and closed approaches. So now it is more or less settled that in case you want to do something for the tip and do a complete rhinoplasty, do something for the septum, do something for the internal nasal valve, open rhinoplasty is a better approach, but to each his own. People are now moving towards internal again. It is a complete cycle, but we'll discuss external rhinoplasty. The aim is to obtain a good exposure. It gives you a binocular vision. You can assess all the deformities and address one by one. So let's discuss various incisions which are there. They could be intranasal and extranasal. So intranasal incisions classically are intercartilaginous, transcartilaginous, transfixational, and marginal or rim incision, which is commonly called. So intercartilages, as the name signifies, it between the two cartilages, between upper and lower lateral cartilages. When you will put a double nasal hook, you will see a prominent line called as limal nasi between these two, the upper and lower lateral cartilages. That is the site of incision, and it is at the cephalic margin of the lower lateral cartilage and caudal margin of the upper lateral cartilages. So it will provide you exposure in case you want to do something to the mid vault, like you want to do something only for the dorsum and you don't want to address the internal nasal valve area, then it is a good incision. And then just in continuity is the transcartilaginous incision. As the name signified, it goes across the cartilage, and here the cartilage is lower lateral cartilage. So this is a form of closed approach only, in which 3 to 5 millimeter caudal part of the cephalic margin of the alar cartilage needs to be divided, and it has to be brought out in delivery technique. So this is one of the ways of addressing the tip using a closed or semi-closed approach, which is not very popular these days. So then we talked about the lateral incision. Now is the midline incisions. There are transfixation incision. They could be hemi-transfixation, complete transfixation, or incomplete incision. What are these? Hemi-transfixation means when the incision is only on one side of the nose. It is not through and through. Complete transfixation enters from one aspect and goes to the opposite side. That is complete transfixation. And incomplete is when the upper part, the septum is divided completely, but the membranous septum is divided completely, but the attachment of the foot plate is kept attached to the septum. The fibrous attachment is kept intact. So more commonly used is marginal incision or the rim incision, as we say, for open approach. So it goes along the caudal margin of the alar cartilage, and it is combined with columellar incision for complete access to the nasal framework in open approach. So open rhinoplasty, marginal rim incision along the caudal margin of alar cartilage on one side, similar incision on the opposite side, which is joined together by a transverse incision across the columella. So another thing which is important to know in the columellar incision is it has to be given in the narrowest part of the columella so that a scar load is less and it is less visible, and you have to break the scar. This can be either a stair step, each one has its own proponents. It could be chevron type, inverted chevron, curvilinear, or W-shaped incision. But the bottom line is the incision has to be broken so that the scar doesn't contract and the incision is not visible after 3 to 6 months of surgery. Then comes, after the incisions, you have given the incisions, how to elevate the skin flap. So let's learn a bit about the anatomy. This is important because when we are degloving the nose, what we want is to preserve the vascular anatomy, the vascularity of the skin flap. And also we want a bloodless field. So it consists of skin, fibromuscular layer, deep fatty layer, pericondylar, periosteal layer. So arteries and veins of the nose are situated in the deep fatty layer. So we want, in case you want to don't want to injure the vessels and want a bloodless field, it is best to go deep to the fatty tissue, but immediately superficial to the perichondrium. So you have to do supraperichondrial dissection. So this way you can have a clean field without any staining of the areas. So once you have elevated the skin envelope, you have to dissect all over the lower lateral cartilages and right on the bony dorsum. But once you reach the junction of the upper lateral cartilage and the bone, nasal bone, never go deep to the nasal bone, because you don't want to, because that will detach the upper lateral cartilage from the nasal bone and lead to something known as inverted V deformity, something like this. So this is very difficult to correct. So best is not to have this deformity in the first place. So after this, you have elevated the whole of the skin envelope. You want, in case you want to do something to the septum, whether you want to correct the deformity, whether you want to take the septum for bone grafts, for the cartilage grafts, then you have to decide how to go about it. Various approaches. You can go directly between the alar cartilages, or you can go from top-down approach, that is after separating upper lateral cartilages, or bidirectional in case you want to use both these methods. So the bottom line is, in case you don't want to do anything to the upper lateral cartilage, you want to do only some tip work and you want to address maybe the caudal dislocation of septum, you can go through between the alar cartilages, something like this. But in case you want to harvest the cartilage graft and there is a strong deformity of the cartilage, you have to do top-down approach. More often than not in most of the cases, we end up doing a bidirectional approach. This gives the excellent exposure to the cartilage and you can harvest the cartilage graft, but only care to be taken is at least 15 millimeter of L strut has to be preserved, and you should not do anything which will detach this L strut from the bony part. Otherwise you have to fix it. So best is to avoid creating all these deformities. So in case you are addressing the primary case, that will give you adequate septum for your cartilage work. Otherwise, in case of secondary rhinoplasty, in which the septum has already been taken or septum is damaged or fibrous, then you might have to go to the ribs. Another important thing is the component dorsal reduction, because most of the cases we see in our subcontinent are in which we want to reduce the dorsum. You see, this is the cartilage, this is the bone, and as we have learned in the earlier part, that this is the thinnest part of the skin. So we don't want any deformity here, any irregularity or any step here. So we want to have equal height as well as equal width between the bony and the cartilaginous mid-vault. So this area is very important, called as keystone area. So keystone area consists of 3 bones and 3 cartilages. We have already talked about it. And this is very important that we don't damage anything in this particular part. Otherwise, deformity is very inverted V deformity will happen, which is very difficult to correct. So how to go about it? So in an attempt to establish equal height and width between bony and cartilaginous mid-vault, what first we'll do, submucopericondyal elevation. We'll give an incision, elevate mucopericondyal flaps, and then we'll separate the upper lateral cartilages from the dorsal septum and create these tunnels in the subpericondyal plane on either side. This will give us the exposure to whole of the and protect these cartilages and mucosa. This will give us access to whole of the bone, and we can the bone can be rasped like this, and after rasping, this will leave us with the excess of cartilage, septal cartilage. The lateral cartilages are upper lateral are preserved. The septum is in excess. We have to incrementally reduce it. So this will ensure that the width as well as height of the bony as well as cartilaginous vault is maintained, and this is something called as component dorsal reduction. And this is all an attempt to prevent inverted V deformity. Something like this. So after component dorsal reduction, we are likely to end up with, and we have created a uniform dorsum, but now it is open. This is called as open roof deformity or open book deformity. So how to correct it? So we need to do something on the lateral aspect. That is, we have to do osteotomies to bring these two parts of the roof together so that the dorsal lines are aesthetic. Another reason for osteotomy is when there is a lot of widening of the bony base. To narrow the bony base, or to there is a crooked nose with both bony as well as the cartilaginous components more on the lateral aspect. So then we have to do these osteotomies, and very rarely we want to widen the bony base. Then we might again have to do osteotomy. So what are various osteotomies? Just to enumerate, let's talk about the lateral osteotomy first. Depending on the incision, you would have seen internal or external osteotomy. What are these? Internal is when you don't give an incision on the skin, you use the mucosa or the elevated skin envelope to give the osteotomy. And external is when you go across the skin. There may be very minor nicks, but still you go across the skin, then they're external osteotomy. Then on the basis of way it is done. Usually it could be multiple perforating cuts and then green sticking it, or it can be a continuous cut with the osteotome. So usually it is reserved for internal osteotomy. Multiple perforating cuts are used using external osteotomy. Another confusing term is you would have seen in notes or of your consultants, osteotomy done low to low, low to high, high to low. What are these? So you look at this diagram. There is a plane across the nasal spine and the orbital rim. This is the plane. So anything below it is low, anything above it is high. So depending on the needs of the case, it can be low to low, low to high, or high low high, or whatever may be the case. So what are the benefits of low to high? Low to high goes below the attachment of the inferior turbinate, and as we are moving towards the medial canthus, it moves medially to the nasal bone. So this is low to high. And once we give the osteotomy below the attachment of the inferior turbinate and don't move medially, keep on going in the straight line till we reach the medial canthus, this is low to low. This will give you maximum narrowing, and it could be indicated in very wide bony bases. But the significant problem with the low osteotomy in the lower part is it will lead to airway compromise, and usually we don't want that. And another thing is usually this is concave, so this natural curve of the nasomaxillary junction is lost in case you do low to low osteotomy, but they can be indicated in some cases. And another side effect could be that this could lead to Rocker's deformity. Sometimes what happens is once you're giving the osteotomy, the cut will go a bit higher than the medial canthus. So what will happen? You see something like this. When you're trying to narrow the nose, narrow the base, the upper part will widen up. So this is Rocker's deformity. So you should prevent it from happening. And all in case of you are doing low to low osteotomy, this has to be combined with a transverse osteotomy also. So what is commonly done? Commonly done is, in case the bony base is not very wide and you don't want to compromise the airway, you remain above the attachment of the inferior turbinate. It is high, then you go low, then again you move high in an attempt to meet the median osteotomy. Thereafter, you can give any fading osteotomy here or a transverse osteotomy as the case may be. So this is most commonly done and usually doesn't lead to any airway compromise. Medial osteotomy we already discussed when you're doing removing the hump, whether you're rasping or using an osteotome. So median osteotomy is already done. Sometimes in case there is no hump, you might have to do paramedian osteotomy, something like this. And or do a medial fading osteotomy to meet the lateral counterpart. So this is the osteotomy which is usually done. And then as we bring these two together, the open roof is corrected and the bony base is wide bony base is also corrected. But that leads to another problem. You see, you have removed the cartilage, you have removed the bones, and when they are brought together, this junction between the lateral nasal wall and the septum, it becomes very acute. And we had learnt that this is the area of the internal nasal valve. So which is responsible for more than 50% of the whole of the airway resistance. So we have to do something about it to bring it back to the normal relation. So whenever you remove or you alter the upper lateral cartilages, their attachment to the septum, you have to do something. This something is the spreader grafts. So you see, when you put spreader grafts, this normal relation of this angulation is maintained, and this is put on the either side of the septal cartilages. So what are spreader grafts? Spreader grafts are the grafts which are used to spread the upper lateral cartilages. They open up the internal nasal valve area and also help you in maintaining the aesthetic middle vault. As you know, the skin is very thin here. A sharp projection will look very awkward. A pinched nose appearance will be there. So that is another reason for using spreader grafts. And they can also be used as batten grafts or septal extension grafts in case you want to do something for the septal angle. You want to increase it or you want to lengthen the nose. All these things can be done, but these are beyond the scope of this particular presentation. So usually the length is around 2 to 2.5 centimeter. Height and width of these spreader grafts is 2.5 to 3.5 millimeter. And the best source available in primary rhinoplasty is the septum. But in case it is not available, then you have to use the rib cartilage. Of course, then there is trouble of warping. So again, how to address warping is beyond the scope of this particular presentation. So this is the way the spreader grafts are put on either side of the septum. One of the intraoperative photographs. Now we have addressed the dorsum, we have addressed the hump, and we have corrected the middle wall deformity. How to address the tip? Of course, there are hundreds of ways and a lot of literature about addressing the tip. It will take you a lifetime to learn all those things, but we should, as a resident, we should learn about mainly 5 things. Cephalic resection of lateral crura, medial crural fixation sutures, columellar strut, transdomal suture, interdomal suture. So look at these 2 lower lateral cartilages. So these are lower lateral cartilages. This is the supratip breakpoint. This is the infratip breakpoint. This is the columellar breakpoint. And these are the dome defining points. So when you have a bulbous tip, the lower lateral cartilage will be very large. So in case you do cephalic resection of the lower lateral cartilage along this line, the supratip breakpoint comes down. So this will give so supratip breakpoint is put a bit inferiorly, something like this. So the tip now becomes more aesthetic. That is what is considered desirable in most of the ethnicities, a smaller and a well-defined nose. So this is one of the common methods which is used to cephalic resection of lower lateral cartilages to refine the tip. But you should be very careful, especially in initial stages. You have to preserve 8 to 10 millimeter on the medial aspect and at least 5 to 7 millimeter on the lateral aspect. And in fact, don't do anything to the lateral third of the lateral crust at all, because that will lead to lateral wall collapse. And in case you do excessive cephalic trim, that will weaken the lateral crust, and that can lead to retraction while inspiring, or even lead to some notching. So you would have seen some over-enthusiastic rhinoplasties being done in which they give an operated appearance with lot of retraction and notching of the lower lateral cartilages, and there is try to collapse, there is collapse when the patient is inspiring, and that doesn't look natural at all, and then also can lead to external nasal wall dysfunction. So in initial phases, you should err on the side of preserving more. You can always go in and excise more in the secondary setting. The second what you should know is the tip refinement method is medial crural fixation suture. Why would you need to do crural fixation on the medial aspect? Primarily to address the columellar asymmetries. Sometimes the columella is very wide. How to address that? You cannot excise the skin. You have to address the cartilages. So you can do these sutures placed along the middle third of the medial crura and bring them in the midline and try to reduce the width, and as the skin drapes over it, the columella width will decrease. This method can also be used to increase the nasal tip projection with something which is known as tongue in groove technique, in which as you keep on suturing, you suture it higher and higher up, try to push the whole of these lower lateral cartilages towards the septal angle. That will increase the nasal tip projection. And best is to use these suture and combine it with columellar strut graft. That is our another surgical technique we should know. What is columellar strut graft? It is a cartilaginous strut which is put in between the two middle crura, and which supports both these lower one-third construct. This is especially required in cleft rhinoplasties. Otherwise, also in rhinoplasties in which you have altered the relationship between these two cartilages, is better to put it. So this is how it is put. Earlier there was a trend of fixing it in the lower part to the maxillary crest. Now most of the surgeons would not fix it and leave it free floating, which will give a more natural appearance to the nose. Then another thing is transdomal suture. Transdomal, you are addressing only a single dome and the suture is going across it, making it transdomal. What is the aim? To increase the tip projection. Why would you need that? In case there is some domal asymmetry. You see one side is very bulbous, one side is narrow. How to address it? Use transdomal suture. And this is primarily a horizontal mattress suture across the lateral aspect and the middle aspects of the dome. And the more further you are away from the dome, the higher the tip projection you will get. Then there is interdomal suture. This is also very commonly done procedure, primarily to increase the tip projection, also decrease the angle of domal divergence. You see sometimes the classical appearance of bifid nose is there. You look at Ravina Tandon's nose. There is increased angle of domal divergence. So that can be corrected using this method. Primarily they will narrow the tip defining points and also will refine the infratip lobule. Again, these are horizontal mattress sutures pass between domal segment of the middle crura, not the middle crura of the lower lateral cartilages. Then finally, there is closure and splinting. You all know about it. The sutures you should use should be the finest possible. It should be a monofilament. It should not be a braided suture. And usually people will use monocryl or PDS or even ethylone. And then you can use a classical ribbon gauze pack on either side or a Merocell pack and splint the skin with steri-strips. And again, in case you have done bony work, you use a thermoplastic splint so that while sleeping the bony alteration is not disturbed. Another thing you should be aware about is that whenever you have done bony work, there is a lot of ecchymosis and edema, and this lasts up to close to 2 to 3 weeks. So you have to tell the patient that for 2 weeks he will not be able to address his work duties, especially in case who is dealing with public, in which public dealing is there. and because nobody wants an operated nose look. So you have to tell the patient. Now there are various methods which are available which can reduce this edema. One of them is to use piezosurgery in case in these cases instead of bony the osteotomes, the classical conventional osteotomes, will use piezosurgery system for these osteotomies. There are various benefits. Past 3-4 years we have been using it in some patients, and just give you a day one picture of these comparison photograph. This of course is not the part of this particular presentation. So all these patients have almost similar bony work done. There is hardly any edema there is some edema in this particular patient and some ecchymosis in this, but this is significantly lower than a regular conventional open rhinoplasty patient in which you have done bony work. So this is the edema and ecchymosis timeline, especially for piezosurgery. For a conventional, it will be delayed further by 2 to 3 weeks. So by day 7, there is some edema of the nose. Maybe I think in this patient here, a Turkish delight also was done. So there is some fullness here. But by day 30, there is hardly any edema, and most of the edema of the dorsum of the nose and the tip. Tip is one area which shows a lot of edema, especially in our subcontinent, because lower part of the nose, the skin is very thick, and this edema takes a lot longer to go. So this is the way using newer methods can help improve the overall morbidity of the patients. Just a few cases just to conclude. So this patient has significant supratip deformity. You see in all the aspects is visible, and you look at his the junction of the lower lateral and upper lateral cartilage, how large they are. So after rhinoplasty, I think it is the same patient. Yeah, same patient. This was what was done. This is the importance of Gunter's diagram, in which Turkish delight was done, and lateral osteotomy, high, low, high was done on both the side, and columnar stud graft was kept. This patient, no cartilage resection was done because I remember this patient was a post-traumatic case and there was hardly any cartilage which was left. So yeah, this patient has dorsum hump extending onto the cartilaginous part, significant extension and very long nose. You see 1/3 concept which we learned. So what we have to do, in case you simply remove the dorsal hump, this patient who already has a long nose will have significantly more appearance of a very long nose. So here comes the importance of reducing the septal angle. Again, this is not part of this discussion. So I think he looks okay. I think this is some edema is there around 1 month old photograph. Another case who has supratip depression and some dorsal hump. So most of deformities are corrected, but in case you look at this particular photograph in the middle, the tip still is trying to diverge to opposite side. I think this needs to be corrected. Another patient with the dorsal hump and drooping tip. I think we have improved the nasal tip projection as well as nasal tip rotation angle. You see, this is the tip projection, and this is when the tip moves out, it is a tip rotation, and also improved the dorsal hump and nasal aesthetic lines in this particular patient. So to summarize, my advice is that you should use general anesthesia, though many people will vouch by using local anesthesia, highlighting that there will be lesser blood loss. But usually doing an open rhinoplasty in initial part of your, especially when you have to do the complete work, it is going to take more than 3 hours. So patient, even with sedation, will not be comfortable. So for the comfort of the patient as well as the surgeon, it's better to use general anesthesia. And infiltration, don't use 1:2 lakh, use 1:80,000, which usually dental people will have this particular concentration, and wait for close to 10 minutes. And this extra 3 minutes you wait will be compensated nicely by a bloodless field, and you will proceed faster in surgery. And there won't be any unnecessary bleeding or staining of the tissues, because then it is difficult to identify the planes. And after this, elevate the skin envelope. After elevating the skin envelope, do the septal exposure through various methods, usually combined approach. and then correct any septal deformity or use septum for graft, and thereafter do incremental hump reduction, use rasps for the bone or piezo system in case you want to use that, and then scissors for the cartilage. Thereafter go ahead with osteotomy. Whatever cartilage you have harvested, whether it is rib cartilage or septal cartilage, go ahead with graft preparation. And more often than not, in an open rhinoplasty, you'll end up using spreader grafts. And in case you have done some tip work to support the whole of the construct, you will need a columella strut, and you will need some tip sutures to refine the tip. Then there is closure and splintage. So the key to good outcome is a systematic approach. So that is most important. First, analyze the problem, address what you want to do, and then execute it in a stepwise manner. And chances are you'll end up with a good result. Thank you.
Nice presentation.
Thank you.
Dr. Athul Parashar, thanks a lot for a very nice presentation. But I myself normally what what we do is earlier we used to have a competition between open approach and closed approach.
Yeah.
At some point of time, we were also doing semi-open, semi-closed, all kinds of things. Now, I fully agree with you that we do only open approach and no more closed approach. It's not the question of experience or whatever it is. It's the question of convenience and safety.
Yeah.
I always try to follow the ABC of safety. So always be careful. That is the ABC of safety which I follow. So just follow the open approach only, wherein you can address so many things. Only thing is, as you said, the scar has to be staggered at the middle of the columella. That is the only thing. And a bit of edema will be there that you should always inform the patients well ahead, not to have any marriages or any functions in between after the surgery, so that he has to be present. So that always should be there. Then splintage, effective splintage, as you said, I still even put, POP splint only. So that has to be used. And what is your experience, sir, with this PDS plates? Do you use PDS plates anytime? When you
No. They were in vogue around 5-7 years back, but I never ended up using them. So more often, I don't. Maybe there could be some use in case of post-traumatic noses in which there's hardly any upper lateral or lower lateral cartilage which is preserved. So that there could be some use for that. I don't know what has been your experience, sir?
Yeah, I've not used. I've used only in some maxillary fractures. Sometimes I use, because if the anterior wall is so much crumbled. What I do is I just put the PDS plate, and over that I just put the bony components, and maybe if I'm able to take some suture, just stick it with the clot, whatever blood clot which is available, and then leave it. I've not used it in the nasal surgery. That is why I'm just asking you.
Yeah, no. Because, maybe Dr. Bhattacharya has some experience on that.
Yeah, I have not used these PDS at all, but I use, of course, the cartilage start or the rib graft.
Yeah.
But I thoroughly enjoyed the way you dealt the critical analysis of every case, and the definitions which you made very clear to the residents especially.
Yeah. Yes.
I have few queries for the benefit of residents.
Yes, sir.
In open rhinoplasty, do you deglove the mucosal side also?
Yeah, in case you want to address the upper lateral cartilages, so you have to deglove it. You should not say degloving. You have to do subperiosteal dissection in the middle part of the septum. That is all we need.
No, not septum. I'm talking about the lower lateral cartilage and of course, the medial crus. Do you dissect the mucosa?
No. I've seen I've visited quite Turkish surgeons. They will usually do it, but I never felt the need.
Yeah, so, because that is one area which some people do and some people doesn't.
Yeah, once they do, they end up putting these baton grafts on either side. Yes. So, but let's say in case you want, there is already a operated nose, then you might have to deglove it. You want to put a graft, then you might have to do it.
Or sometimes in post-traumatic.
Post-traumatic, exactly.
Yes. And the second thing is that if you have to use a silastic implant, would you consider along with the open rhinoplasty?
Actually, silastic I have never used. They give very good results initially, but now we are happy with our Turkish delight, and maybe we have some experience with tissue glue with these grafts. So in open rhinoplasty, so I've never actually, unfortunately, I've never used.
So when I use it sometimes, because when you have to do a bilateral osteotomy for wide nasal root, and then one has to be very careful that the central pocket for the implant and the two osteotomy pockets should not communicate. That is the only precaution one has to take. So when you do the first osteotomy, you should be careful to visualize that the central pocket for silastic implant remains intact.
Yeah, exactly.
So this is the only precaution. And then the other thing is for hump, will you do rasping or osteotomy? What is your preferred? Or it depends on the case.
Yeah, till 5-6 years back, I was using more of rasping for the hump because that was easier and it was very much controlled. And sometimes you end up saving the upper lateral cartilages and open book deformity does not form. So recently we have started using piezoelectric system. So in which there is a bone rasper is there. So, so that is very effective. It incrementally removes and there is no open roof formed. So rasping is my choice, whether using a conventional instrument or using a piezo system.
And especially for juniors, when they do osteotomy, if they do more than required, then they'll be in trouble. So rasping is always better.
Yeah.
And any use of ear cartilage?
Yeah, in case of say cleft rhinoplasty, in which ipsilateral lower lateral cartilage is deficient, then conchal cartilage contours well, and yeah, that is one use. And in case you can take some of
natural
curvature to it, and in case you can harvest some the septal cartilage, that also serves as a strut, columnar strut also.
Right.
For cleft rhinoplasty, I've used. Yeah.
And the one suggestion I would like to give to all, that to reduce the edema, you use dexamethasone 8 milligram intramuscular twice a day. That's all. Any facial injury case or rhinoplasty, and you see the result yourself. It tremendously reduces the edema, apart from other splinting, etc. So dexamethasone I always use. One intramuscular, not intravenous. It should gradually get absorbed, and only for 2 days. 8 milligram intramuscular for 2 days. I thoroughly enjoyed your presentation. Very nice. Very nice.
Dr.
Excellent presentation, Dr. Athul.
Dr. Lakshmi. Sir, when I do osteotomy, if there is any chance of mucosa getting exposed, I don't use any kind of implants. For that matter, nowadays we don't use implants at all. We use only autologous cartilages, because I've had 2-3 instances wherein we had to pull out the implant, done by some other people. So when there is an exposure of mucosa, I never try to use the implants. And whenever I want to do an osteotomy, that case also I just avoid the implants. And as you said, the steroids we use lavishly. In fact, for 2 to 3 days we use, so that the edema reduces grossly. And piezoelectric, I just want to ask Dr. Athul, what is the make which you are using, sir? Piezoelectric?
No, primarily what we are using is, I'm not remembering the name. It is meant for maxillary system. It is an osteotomy system. It is not the Marina make, which is classically meant for rhinoplasty system. So we are in process of getting that.
Okay.
So it is the Leafort 1 osteotomy system which we have got. But since we have got this bone shaver attachment, that really helps. And lateral osteotomy can be done with a similar system. We don't have Marina system, which is ideally suited for rhinoplasty. So we are in process of getting that.
Okay, you got it as an added attachment. Yes, liver.
Yeah. So not remembering the name, but it is a classical meant for Lefort osteotomies.
Good evening, everyone.
Thanks.
Good evening, everyone. Dr. Athul, it was a very nice presentation. Really wonderful. Very lucid and very clear. I just want to add one thing about Bhattacharya sir's comment. One of our surgeons in medical college, not in our institute, he is using ice packs. Continuously, he is putting ice and he is claiming, I have also seen the result, that there is very, very minimal edema. He is continuously keeping ice packs on the nose, in between removing when the need arises. And he claims that it drastically reduces the post-operative edema. And bleeding is also not much.
Yeah, I think technically, in case you start it early on, it will be beneficial. But practically, like in case splint is there, how would you transfer that coldness or heat out of that? That I was wondering. On putting ice.
Intraoperatively, he is using continuously whenever need arises. I have not seen him operating. I have heard, but I have seen the results also. He is actually a professor in our medical college. No? He's a very old person now. So he is continuously using, and he's always claiming that the edema, post-operative edema is drastically decreased because of cooling of this. I just want to add this thing.
Yeah,
secondly,
that could be interesting.
Please, you continue.
It would be interesting to find, do some study on that, like intraoperative.
I have seen only. I have not seen him operating. Okay. Secondly, I joined actually late. It was different. I don't know what was the glitch there. Did you talk about the osteotomies?
Yeah, I did talk about osteotomies.
Because for the students, they are frequently. Just for the student, they are frequently asked about the high to low, low to high, medial, lateral. I joined actually late.
Yeah, no, I was able to talk around 5-6 slides. I devoted.
He has dealt in detail.
Yes, sir. I joined a little bit late. I messaged him also. Is there something problem? I could not join on time.
It will be uploaded in future if Dr. Athul Parashar.
I joined a little bit late.
No problem.
It was nice one. It was nice one.
Dr. Athul, really you have made the PPT opt for PGs. You have covered all aspects, which is a very practical way you explained. So a very difficult topic made very easy. And I have one doubt. If a patient is having a depressed nose with a short nose, so you augment it and use the extension septal graft and all. How will you address the shortness of the soft tissue?
Usually it depends. In case it is something like a binder syndrome, then you have to take a balance. But otherwise, any short nose skin stretch is there because we hardly want to extend by 4 to 5 millimeters. And with septal extension graft, it is not a trouble. With non-autologous modalities, it could be a trouble. So I don't think addressing the short nose skin envelope could be a trouble, except in case of a binder syndrome's case. So I would use spreader graft and use a long spreader graft, extend it along the septum and bring the septal angle a bit distally and higher. So that is how I address it, and use a Turkish delight on top of it to camouflage any deformity.
I remember when I started learning rhinoplasty from Dr. Narendra Pandya and others long back in early 90s. Then my pastime while I was traveling on train or bus was to do rhinoplasty imaginary in all the people sitting in front of me, because no noses are ideal. So you look at them, but only problem is sometimes they get embarrassed why I'm staring at them. But it is a very nice time pass. that you can do rhinoplasty almost in everybody's nose. You find some deformity, some defect, and you can, operate imaginarily.
Yeah. Virtual rhinoplasty.
Virtual
Yes.
rhinoplasty.
Virtual rhinoplasty.
Great,
Yes.
sir.
If there are no questions, we'll go for case